So welcome to this Finals Crash Course series session on hematology, focusing on hematological malignancies, taught by Zara Mohammed. If you look on the top right of the slide, that's our link to our Instagram page. So please follow us and then you'll get all the updates on all the sessions we've got coming up. And on the bottom left is just our email address. So if you have any questions, please get in touch with us and we'll try and get back to you as soon as possible. And then should we go to the next slide? I'll hand it over to Zara now.
Okay, hi everyone. So I'm Zara. I'm one of the internal medical trainees, currently doing my renal rotation at Hammersmith. And I thought I'd give a talk on hematological malignancies today. So just a brief overview of the topics. The main topics I'm going to cover is all the leukemias, lymphomas, and multiple myelomas. So we'll start off with an MCQ. So you have Amy, a 29-year-old female who presents to the GP today with fevers and bruising that she's noticed over the last few days. What would your next step be? I'll just open up the poll. I'll give it a few minutes. Okay. So, yep, the majority voted for C. So that's correct. So you'd refer Amy for urgent bloods within 48 hours, and I'll go on to explain why. But firstly, so we'll just talk about leukemias. So Amy's presentation was of an acute leukemia. And leukemias are sort of neoplastic proliferations of white blood cells. They're not solid tumours, and they're differentiated into acute versus chronic, or myeloid versus lymphocytic. So investigations in general that you do if you were suspecting a leukemia. So in Amy's case, if she's referred within 48 hours, these are the investigations that would be done as part of her workup. So she'd have blood tests at the first instance, and this would show an elevated white cell count. She'd have a blood film, which would show the presence of abnormal cell types, and I'll explain a little bit more about these depending on the type of leukemia. And she'd have, at some point, if there was, she'd have a bone marrow biopsy to sort of clinch the diagnosis. So the reason for Amy's is as per the NICE guidelines. So in any child, if anyone presents with hepatosplenomegaly or unexplained rashes, that's a criteria to immediately refer to the pediatric team in hospital. And adults or children, so anyone else essentially, if they have any evidence of acute pallor, persistent fatigue, unexplained bruising, lymphadenopathy, or unexplained fevers, they would be sort of indications to refer urgently within 48 hours for bloods, for the full blood count. So we'll talk about acute lymphoblastic leukemia. So essentially it's proliferation of immature lymphoblasts in the bone marrow. So lymphoblasts essentially mean immature lymphocytes, and that leads to the bone marrow to fail as the cells are infiltrating the tissue. And that essentially affects the normal production of blood cells. So when it affects the red cells, it can lead to anemia. When it affects the production of platelets, it leads to thrombocytopenia. So patients may present with bruising. And when it affects, the white cells in general, it can cause neutropenia. So patients may present with frequent sort of infections. So it's the most common malignancy of childhood. So this is probably the most likely case in someone who presents how Amy presents. Obviously, she is 29, but she would still be sort of within that sort of young adult bracket, and that is the most common malignancy in young adults. So features, so we talked about the features of bone marrow failure. Patients may present with fevers, often with no obvious source. And this can either be as a direct consequence of an infection, or it can be a sort of inflammatory response of the body to the malignancy. and patients may present with bony pain, and that's because the cells infiltrate the bone marrow. The tests that are done, so I mentioned biopsy. So what a biopsy would show in acute lymphoblastic leukemia would be a proportion of immature lymphocytes more than 20%. And these lymphocytes would have the characteristic appearance on blood film of very, very large nuclei, because there's lots of, they're very premature and small amounts of cytoplasm. So you can see in the blood film, the dark purple is the nucleus. So it's very, very big. The light purple is the cytoplasm. So you can see that there's not very much. So it's a very immature cell. And then once the diagnosis is sort of confirmed, then further investigations would be things like trying to stage the condition. So you'd do an X-ray in the first instance, then you'd want to do a CT, chest, abdomen, pelvis. If you're considering sort of CNS involvement, then a lumbar puncture as well. And essentially management is chemotherapy. Patients would be considered for a bone marrow transplant, which is a curative for the condition. And overall, it has a fairly good prognosis. So the second question is Stephen is 26. He presents to the clinic with fatigue and recurrent infections. A diagnostic of acute myeloid leukemia is suspected in his case. Which of the following is not a classic feature of AML? So I'll just open up the poll and give it some time. Okay. So the majority of you said A, which is correct. So I'll go through the question. So the reason why it's not DIC, so DIC can occur in a particular subtype of AML known as the M3 subtype. So DIC is, a common feature of AML. Gum hypertrophy is a feature. Conjunctival pallor can occur due to the anemia, and hepatosplenomegaly is also occurring. The reason why it's not lytic bone lesions is that AML tends to more sort of infiltrate the bone and cause pain, but it doesn't cause the classic lytic bone lesions, and that's more of a feature of myeloma. So acute myeloid leukemia. So it's a neoplastic proliferation of immature myeloid cells. So the difference between this and ALL is that ALL cells are sort of from the lymphocyte chain, whereas AML is the sort of myeloid cell. So this would include things like, granulocytes, eosinophils, basophils, and this is the commonest one in adults. And there's multiple classifications. So this table shows that, the different subtypes and what they're called. For sort of finals perspective at your level, you probably don't need to know about all the specific types. The main thing to remember is the M3 subtype. And that's the key points to remember I've highlighted. So just remember the translocation that's involved. It's involves chromosomes 17 and 15. And it causes a fusion of the PML and the RAR alpha gene. And this is associated with DIC, as I mentioned. And the treatment of that involves targeting the fusion gene with all-trans retinoic acid. And what that does is that it binds to the gene, which leads to an altered receptor, and that allows the blast cells to then mature. So causes of causes of AML. So in patients with sort of a more chronic myeloid leukemia, in some cases, the cells can rapidly proliferate, and that can cause AML. Previous exposure to radiotherapy or previous exposure to certain toxins as well can increase the risk of developing it. In terms of features, so fairly similar to ALL in the sort of bone marrow failure features, but other features would include infiltration of other cells and organs, and it can commonly present with hepatosplenomegaly, gum hypertrophy, and bone pain. So for the final sort of perspective, questions commonly ask about gum hypertrophy, so that's just something to remember. Leukemia cutis, that's quite rare, but essentially the blast cells infiltrate the skin and that leads to purple patches. A biopsy, the sort of histology shows the classic blast cells, but there's one feature that's very specific to AML, which is known as the hour rods, which is a sort of lines that you see in the cells, as you can see in this image here. So for example, a finals question might have, you know, a cell like this showing the line and ask you to, you know, make a spot diagnosis. And that would, you know, it would be AML. And management, again, very similar to ALL, you know, combinations of chemotherapy. The specific chemo would be sort of as per the sort of newest developments and what the hematologist, you know, advises. But, you know, apart from chemo, there's also bone marrow transplant as well. So the next MCQ, you have Mr. Smith, who's 81, and he presents with fatigue. He has a blood film which shows the following. What underlying condition is consistent with his blood film? So I'll give you some time and open up the poll. Okay, so the answer is CLL, and majority of you were correct. So the reason why it's CLL is you can see on the sort of right-hand side of the image, there's a very sort of blurred out kind of cell. It looks as if someone's essentially smudged. If this were a drawing or painting, it looks like someone's smudged one of the cells. So that's known as a smear cell or smudge cell. And that's a sort of characteristic feature in blood film of chronic lymphocytic leukemia. So I'll go on and talk about what that is. So this is similar to ALL. However, the difference is that it's a more chronic picture, and the proliferation is not of lymphoblasts, but it's actually of mature lymphocytes, and it usually is quite insidious. It sort of presents in more elderly patients, and it can occur quite slowly. It's essentially the lymphocytes are B cells. However, unlike other normal B cells, these ones aren't functioning. So they don't produce antibodies or normal antibodies. And these B cells express CD5 and CD20, which are important markers, when targeting treatment options. So the blood film I mentioned, so classic smear or smudge cells. So for your finals, just that's something to be aware of in terms of a specific feature of CLL. Complications. So CLL is often linked to an autoimmune hemolytic anemia. Again, it can cause the bone marrow failure and infiltration type features. So like with all the other leukemias, infection, bleeding, anemias and hepatosplenomegaly. And because the B cells are non-functioning, that leads to a lower level of antibodies. So that's another reason why there's an increased risk of infections in these patients. And one important complication to be aware of that I've highlighted is Richter syndrome. So that's when a CLL that, it may be indolent for a while, then all of a sudden, the leukemia cells enter the lymph nodes, and sort of this causes a rapidly growing high-grade lymphoma. So the CLL is essentially transformed into this lymphoma, and the patients can become suddenly ill with weight loss, nausea, lymphadenopathy, and fevers. So that's a very aggressive high-grade transformation. In general, management of the CLL, in some patients, if they're minimal symptoms, a small amount of hepatomegaly, if they're well otherwise, they may just be enrolled in sort of watchful waiting, so have regular clinic follow-up just to make sure that the disease is not rapidly progressing. There's certain criteria which, you know, I don't believe you need to know at your level, but there is certain criteria which, if you're interested, you can look at the NICE guidelines where, you know, if certain thresholds are met, then the CLL is treated. And if they are treating, a common chemo regimen is FCR, so fludarabine, cyclophosphamide, and rituximab. Okay, so the next question. Beatrice is 67 and she attends clinic after a recent diagnosis of CML. Genetic studies reveal chromosome T922 translocation. Which of the following is a good treatment option for her? I'll just open up the poll and give you some time. Okay, so majority of you said E, which is the correct answer. So I'll go on to discuss why. So let's talk about, sorry, that's meant to say CML in brackets, but let's talk about CML. So chronic myeloid leukemia, it's a proliferation of the mature myeloid cells. So that's what makes it different from AML. And it's obviously not acute. It's more common in elderly patients around the age of 70. It's not common in childhood. And the chromosome 9, chromosome 22 translocation is known as the Philadelphia chromosome. And that's actually associated with good prognosis. So that translocation makes a specific protein, a BCR-ABL fusion protein. And this protein mutation leads to excess tyrosine kinase activity. And this is the reason why it's good prognosis, because that can actually be targeted with treatment. So imatinib, which was the answer in the previous question, is, you know, a good treatment to target that, as it inhibits TK, so tyrosine kinase. So features of CML would include, you know, it's a very insidious onset. Patients may present with sort of weight loss, fatigue, fever, night sweats. The difference between CLL and CML is that sort of CML tends to have a massive splenomegaly, whereas CLL tends to have, you know, not as significant. And CML can progress to acute lymphoblastic or myeloid leukemia. And, you know, the myeloid cells can pose an increased risk of thrombosis as well. And blood film would show many sort of white cells at different sort of levels of maturation. So this, you can see that there's quite a lot of cells, and they all are sort of different sizes, different amount of nuclei. And that's how a common CML appearance would be on a blood film. And we mentioned in terms of management the imatinib, but, you know, obviously bone marrow transplant is also something that's considered, especially in younger patients. So next question, you have Michael, who's 44, and he's received a recent hematological diagnosis after presenting with a lump in his neck. His blood film shows the following. Which of the following is a classical feature of his condition? So I'll open up the poll. Okay, give you a few more seconds. Okay, so the majority of you said A, which is correct. So before I go on to explain, let's just talk about lymphomas. So what do we all think Michael's condition is? So the blood film shows the classic owl's eye appearance. You can see the two nuclei there next to each other, and that's classical with Hodgkin's lymphoma. So we'll just talk about lymphomas firstly in general. So this is a proliferation of lymphocytes, but that accumulate in the lymph nodes. And unlike leukemia, it's a solid tumor. And these are divided into Hodgkin's and non-Hodgkin's. So the classical feature of Hodgkin's would be the Rien-Sternberg cells. So that's the owl's eye cells, which is what I was on the blood film before. So they're B cells with prominent nucleoli in their multi-lobed nuclei. And there's 4 different subtypes of Hodgkin's. So you don't need to know too much detail about them, but I've just written sort of which one's more common, which one has the best prognosis, and which one has the worst prognosis. So nodular sclerosis, that's the most common one. The best one is the lymphocyte rich, and lymphocyte poor is the worst one. And the atypical Hodgkin's has a classic feature known as popcorn cells. And then non-Hodgkin's, so they don't have the classic Reed-Sternberg cells. And these are split into multiple different types, but in general, there's low-grade types and high-grade types. The high-grade ones, although they are quite aggressive and have, a worse prognosis, they're often more likely to be curable in the early stages compared to the low-grade ones, which are less likely to be curable. So Hodgkin's, let's talk about that. So risk factors, certain viruses, so EBV, HIV, and history of immunosuppression. Features would be enlarged nodes, which are quite superficial. Commonly, you can get them in the neck or the mediastinum, and they're often painless. So a common way that Hodgkin's presents is a fairly young patient with a lump in their neck, which they've noticed. And for exam purposes, I don't know how common this actually is in practice, but to remember that the lymph nodes, so the enlarged nodes, often cause pain only when they drink alcohol. Otherwise, it's painless. So that's why I've put that in the MCQ, because that's just something worth noting. If you have significant mediastinal nodes, they can cause chest symptoms, so they can obstruct the sort of bronchial vessels or the superior venous cava. And if they affect the bronchial vessels, it can present with hemoptysis, shortness of breath, and coughing. These have classic sort of B symptoms, which are associated with lymphomas. And this includes weight loss, fevers, and night sweats. And for the weight loss to be significant, it's usually more than 10%. Over a 6-month period. And there's a classic name for the fevers that you get in Hodgkin's lymphoma. And these are sort of cyclical fevers, and it's called Pal-Epstein. So to diagnose the condition, you'd want to do a biopsy of the lymph node and look at the histology. And as mentioned, it would show the classic owl's eye appearance of the cells. Hodgkin's lymphoma is staged via the Ann Arbor system. And this system essentially depends on the number of nodes, the location of the nodes, so how many nodes on one side of the diaphragm, and if there's involvement in either side, and then if there's involvement of the disease, out of the nodes. And then you usually add an A or a B, depending if there's B symptoms present. So the sort of stage 1 would be just affecting one lymph node. Stage 2, if there's more than one lymph node, but only in one side of the diaphragm. And then stage 3 would be nodes on both sides. And stage 4 would be extranodal. And management of Hodgkin's usually is chemotherapy. And an example of a regimen is the ABVD regimen, which is adriamycin, bleomycin, vinblastine, and dacarbazine. And usually, these are often ever changing, and there's always new developments in the management. So, always check the NICE guidelines, trust policies, and, it'll be the decision of the hematologists. So the next one would be non-Hodgkin's lymphoma. And the risk factors for these, again, are viruses, autoimmune conditions. A common one is Sjögren's syndrome, which is associated with it. And there are various types. So I've got a table on the next slide. So we'll go through that. But the sort of symptoms, so again, it can have superficial lymphadenopathy, but this actually has more likely to have an extranodal disease as well. So it commonly involves the gut and affects the lungs as well, and the bone marrow. Compared to Hodgkin's, there's no alcohol-induced pain, and B symptoms are less common and they tend to occur later than Hodgkin's. And how the disease is diagnosed is bloods, so obviously would show raised white cell count, may have elevated LDH and elevated inflammatory markers. And again, a lymph node biopsy is essential to clinch the diagnosis. And management would be chemotherapy plus minus radiotherapy, depending on the location of the nodes. And if the lymph nodes are significantly large, they may need surgery to remove them. So this is a table just showing the different types of non-Hodgkin's. Don't think you need to know too much detail about the types, but I've just highlighted a few points to remember. So the follicular one, they sort of small amount of B cells proliferating, and it forms a sort of follicle-like nodule. Chromosome involvement is 14 to 18 translocation, and this tends to be more of a low grade, but in some cases it can transform into a diffuse large, B cell lymphoma. The next one is marginal zone. So that's the proliferation of B cells, which expand into the lymph node marginal zone. So that's an area of the actual lymph node. But the thing to remember with this one is that it's associated with chronic inflammation. So Hashimoto's or H. pylori infection is associated with this type of lymphoma. Then there's the diffuse large B cell lymphoma. So this is an aggressive form. It's the most common form. And it's, large B cells, they tend to grow in sheets. And finally, there's Burkitt's. Burkitt's is sort of proliferation of medium-sized B cells. This tends to be the most aggressive form, and it's due to a gene translocation. It's the C-MyC, and this involves chromosome 18 and 14. And this has an association with EBV virus. And just for exam purposes, things to be aware of is that histology would have a starry sky appearance. And that's because it's got B cells, macrophages, and sort of dead cells all sort of mixed in there in the sort of sample. And there's two types. I wouldn't go into too much detail about the two types, but African type usually involves the jaw, whereas the sporadic form tends to involve the abdomen. So you tend to have tumors in the gut, such as ileocecal tumors. So this MCQ 6. So Jack presents to the hematology clinic after testing positive for a JAK2 mutation. Which of the following is not consistent with the underlying diagnosis? So let me open up the poll. Give you a few seconds. Okay. So palpitations. So we'll just talk through. So essentially what Jack has, so JAK2 mutation. I actually didn't pick the name on purpose, but a JAK2 mutation is something that's commonly involved in different myeloproliferative disorders. So it's essentially a proliferation of mature cells of the myeloid lineage, and usually the cells of all myeloid lineages are increased. And again, the JAK2 kinase mutation is involved. And the complications of this is that there's a high cell turnover, which can lead to gout, bone marrow fibrosis, and progression to acute leukemia. There's a large number of cells in the circulation, which can cause hyperviscosity and thrombosis, and that can cause headaches, blurry vision, and hypertension, which were mentioned in the question. And so when the red cells are involved, it causes polycythemia vera. When the platelets are involved, it's known as essential thrombocytopenia. And then there's two others. So there's myelodysplasia. So that's sort of hematopoietic stem cells, so sort of myeloid cells, which sort of are rapidly proliferating, but it's not yet reached the malignancy stage. but this can progress to acute myeloid leukemia. And then there's myelofibrosis. So that involves megakaryocytes. So that's the precursor to platelets. And that's when these megakaryocytes are proliferating rapidly, and that causes massive splenomegaly and teardrop cells. So if we go back to the question, the reason why itching after hot baths is not the right answer is because, especially in polycythemia vera, because there's a high number of red cells, this leads to, when patients are exposed to heat, it can lead to sort of vasodilation and a huge amount of cells being there, and that can cause itching. Gout, as I mentioned, is due to the increased red cell turnover. Blurry vision is due to the sort of thrombotic state, so the hyperviscosity, and again headaches because of the hyperviscosity. But palpitations don't really match any of the features of the diseases. So yeah, just to reiterate, so for exam purposes, if a question mentions teardrop polycytes or massive splenomegaly, think of myelofibrosis. And in terms of hematological malignancies, if there is massive splenomegaly, it's usually it can be two options. So it's either CML or myelofibrosis. That's the ones that cause the massive splenomegaly. And now we'll go on just to talk a little bit about the plasma cell disorders. So that includes multiple myeloma, monoclonal gammopathy of undetermined significance, known as MGUS, and Waldenstrom macroglobulinemia. So essentially, plasma cell disorders are sort of abnormal plasma cell proliferation that causes excess secretion of immunoglobulins and therefore leads to organ dysfunction. So it's the final MCQ. So you have Esme, who's 89. She's referred to the heme clinic with hypercalcemia and anemia. Which of the following would not be useful to ascertain the most likely diagnosis? I'll open up the poll. Okay, so majority of you said renal ultrasound scan, which is correct. And the reason why, so based on the question and the fact that I mentioned that we are going to talk about plasma cell disorders, the diagnosis here is multiple myeloma, and hypercalcemia is a common feature. And a bone marrow biopsy is useful. That essentially is the gold standard to proving the diagnosis. But in all patients, they usually have a whole body MRI to assess for skeletal involvement across the body. They'll have a protein electrophoresis done, and that can show the paraproteins in the blood, and also done in the urine too. And a blood film is useful to ascertain the diagnosis, as it shows a classic rouleaux formation. A renal ultrasound scan is it's not going to help, ascertain the most likely diagnosis. So myeloma can cause renal impairment due to the light chains, but a renal ultrasound scan is useful to identify renal impairment, but it's more done to look at obstructive causes and to exclude that, as well as assess the kidney size. So if you do a renal ultrasound scan on someone with myeloma renal disease, it's not going to sort of tell you that the patient has myeloma. It's just more of a sort of workup as part of the renal screen. And to prove myeloma-induced renal disease, you'll need to actually do a renal biopsy. So multiple myeloma, it's proliferation of plasma cells in the bone marrow. And this leads to bone marrow failure as the plasma cells sort of crowd out hematopoiesis, and leads to the classic features as mentioned before of anemia, bleeding and infections. It tends to be increased osteoclast activity, and that leads to bony lesions, and they tend to be sort of punched out lesions. So earlier on this talk, we mentioned lytic lesions in one of the questions. So they're more of a feature of multiple myeloma. Patients can have pain in the bones, and that's what causes the hypercalcemia as well. And then the sort of abnormal proliferation of the plasma cells leads to an increase in immunoglobulins. And these are often light chains, and this can deposit in the sort of kidneys and cause kidney disease. And they can also lead to a primary AL amyloidosis, so accumulation of these sort of amyloid sort of proteins in different organs. And a way to remember the sort of extra or the classic features of multiple myeloma is CRAB. So C for calcium, so hypercalcemia, R for renal, so renal involvement, A for anemia, and B for sort of the bone disease. And for example, in terms of the tests, in terms of the bone disease specifically, so an X-ray might show a classic, it's called a raindrop skull. So the sort of lesions are also, involve the skull and can involve the whole body. So that's why you do the whole body MRI. But I've already mentioned the investigations on the sort of questions, but yeah, this is just a sort of a summary. So in this blood film, you can see the red blood cells stacked on top of each other. So that's known as the Rulux formation. And management ultimately is chemotherapy or bone marrow transplant. And this would be guided by the sort of staging of the disease, the patient's comorbidities, and the sort of specialists. And the two others, so MGUS. So essentially it's sort of similar to myeloma, however, in the sense that there's an increased clonal antibodies, but there's no CRAB symptoms, so it's not actually defined as multiple myeloma. There's no bony lesions, there's normal immune function, and there's a lower levels of the protein. So that's why the name is, uncertain significance. And the other one is the Waldenstrom macroglobulinemia, and essentially it's like a it's like myeloma. However, the monoclonal cells, monoclonal proteins that are produced are not IgG, it's IgM, and lots of IgM in the blood can cause hyperviscosity, and that can cause the sort of visual and neurological symptoms. And this is commonly found in elderly males. And it can present with B symptoms, organomegaly, and Raynaud's, as well as the hyperviscosity syndromes. And the management would be, targeting the tumor would usually be chemotherapy. And if hyperviscosity is a sort of significant problem, then plasmapheresis is done. So that's when the plasma is obtained and the IgM is removed from the serum. So that's it. Does anyone have any questions?
Thank you so much, Sarah. If you're watching online, please do fill in the feedback form for access to the slides as well. Even if you're watching the YouTube recording, we leave the feedback forms open for a very long time, and we like to get lots of feedback. So please do fill it in.